of the larynx and the trachea when we constantly cough. But chronic bronchitis is not uncommon. And we see that with patients who do have a history of smoking. And as I mentioned earlier, if a person has had asthma as a child or as a young adult, they are more likely to develop chronic bronchitis as they grow older. Another concern we have for our older patients is emphysema. Emphysema, as you remember, it can be caused by many factors. Chronic bronchitis actually can bring on a problem with emphysema because of the constant elongating or the dead space and the alveolus are not functioning. Irritation, any other kind of changes in the lungs. It can be from asbestos, it can be from something in the air, but many causes, and we're seeing an increasing incident of emphysema in our older population. Cigarette smoking plays a major role in the development of emphysema. It takes time for emphysema to really show up over time. It's a slow progress. Unfortunately, we do have some treatments for emphysema, but unfortunately, once the damage has occurred, it is chronic. And so you can live with emphysema for 20, 30, 40 years. And eventually what happens is the patient gets the big barrel chest. It has the extremities become very tiny. Their muscles atrophy even worse because of their lack of an ability to exercise, because they have trouble breathing so much. They're usually on oxygen, usually about 3 liters or less around the clock. They struggle to breathe. They struggle to breathe out because of the damage to the diaphragm and the muscles and the internal lung tissue. They have trouble breathing out, and so they make these strange noises. When they breathe, they're very, very, very anxious. Actually, any patient with a lung problem, such as we've talked about, actually can become so anxious they wind up on anti-anxiety medications because not being able to breathe causes extreme anxiety to our bodies. And then you have the release of epinephrine and all that whole process. Okay. There is treatments, bronchodilators and those types of things, but we really need to support our older patients with emphysema. So here's a clinical judgment related to COPD. And so I want someone to read this. Let me see. Let's find someone who I haven't called today. Who haven't I called? Yvonne?
I'm here.
Okay, would you read this to us and tell us what's happening?
Sure. So COPD developing clinical judgment. An older adult presents to the emergency room with an abrasion requiring stitches on their head and an exacerbation of chronic obstructive pulmonary disease, COPD. Their health history includes 22 years of cigarette smoking, dyspepsia, cholecystectomy last year, and amputation of the 2 lateral fingers of the right hand 4 years ago. Indicate which nursing action listed is appropriate for each potential complication. Note that not all actions will be used.
Okay, so tell us about this patient. What do we see in here? Why is this patient coming to see you today?
So he has an abrasion and he requires stitches.
Okay.
And also he has the COPD exacerbation. He does have a history of 20 years of smoking cigarettes.
Mm-hmm.
The dyspepsia, I guess it's difficulty. Let me see.
Okay.
I'm sorry.
Okay. I don't know whose baby is talking, but
Mine.
is it yours, Yvonne?
Yeah. It's my daughter.
Okay.
I'm sorry.
Oh, your daughter. Okay.
Yes, yes.
All right. Okay. So yes, we have a patient that definitely has COPD. They've smoked for 22 years. What is dyspepsia?
I'm looking. It's difficult.
Indigestion.
Hmm.
Oh, that's just,
Okay. What did you say? Indigestion, like a stomach pain, bloating, heartburn, that kind of thing? All right, burping a lot. So they're having trouble with all of that. And we know that, remember when we talked about hiatal hernias and anything to do with the esophagus, we actually have an increase in COPD problems when we have patients who have that. So apparently this patient here has got the same issues and now they got COPD as well. All right. All right. They had a cholecystectomy, and what is that?
is it the removal of the gallbladder or?
Yeah, very good. Removal of the gallbladder. All right. And they lost 2 fingers 4 years ago, so it's not anything major right now. Now, the patient had some abrasions on their head. We don't know at this point how they got those abrasions, do we? It doesn't say. So now I'm going to give you nursing actions. All right. Let me see if I can move this over. So here is all the nursing actions that I want you to consider. And I'm going to keep these nursing actions open. And what I want you to do, if y'all can turn your slide, if you have a way to do your own slide, go to the potential complications. This is what I want you to do. I want you to look at these are the problems, potentially complication for this patient. Choose one nursing action for each of these. And I gave you the list. They not all may be used. So for instance, on your respiratory infection, what are some of the things, what is one action here on this list that the nurse should be doing for a patient with a respiratory infection? All right. So you may have to kind of write these down so I can leave these actions up here for you. So you might want to write down on a piece of paper a respiratory infection, dysrhythmias, activity intolerance, oral candidiasis, hypoxemia, malnutrition, and anxiety. So these are all potential complications for this patient. Okay, were y'all able to get those written down, or you can see them somewhere on your slides? Now, the answers are at the end of the slide, but I don't want you to look there. I want you to try to do this yourself, okay? So here is the nursing actions. So I'm going to give you a couple of minutes to go through each action. Remember, there's only one answer for each of these complications. So what appropriate nursing action would you do for each of those complications I just gave you? So let's go ahead and do that. You're welcome to work together however class you want to do this. It's kind of hard when you have so many students on here, but I think this is a really important activity to help develop some of those critical thinking skills. I'll give you another minute. Just remember, you're only looking at one nursing action for each of the complications. And then we're going to talk about them. All right. All right, class, are you ready? All right, remember, we're talking about this patient here. We have a patient with COPD, 22 years of smoking, heartburn, those types of things, dyspepsia. Last year they had a coli, or, you have to think about what is the effect of each one of these on this patient. All right, this is a real patient here. And amputation of the fingers, all right, 2 lateral fingers of the right hand 4 years ago. So here's your nursing actions. Amber, are you there?
Yes, I am.
Perfect, Amber. For respiratory infection, which one of these nursing actions would be the best thing for you to implement?
For the respiratory infection, because she was having the COPD exacerbation as well, administer oxygen.
Okay. For infection? Okay. Class, what do you think? I can see why you would say that. What do you think, class?
I was thinking the pursed lip. That way they get full expansion because they already have an infection. So it might be better to expand as much as you can. But that's my thought process.
Okay, well, I love y'all's thought process and keep it up. What's another answer that you might use somebody else?
I think teach the patient to drink at least 2 liters of fluid every day, because to get up all their secretions and everything.
So what happens when you drink a lot of fluid? How does it help the lung secretions?
It's gonna thin them, so it's gonna
Okay.
make it easier to cough everything up and hopefully get better faster.
Okay, excellent. What happens when we have a respiratory infection? What happens to inside the lungs? How does it look? What would you see?
Infiltrates.
Yes. Yes, they would have a lot more thicker and all kinds of gunky stuff, remember, right? So you are correct. The correct answer for respiratory infection is to teach the client to drink at least 2 liters of fluid daily. Now let's go back to pursed lip breathing. That would help with being able to breathe, right? But would it really help the infection, to get rid of this infection? Giving oxygen, we might give oxygen, but when you're thinking about oxygen therapy, how is that going to affect the infection process? So when you're looking at this type of question or this kind of nursing action on these types of questions, you want to think about how is it going to affect specifically what's happening with my patient. So the correct answer, y'all all had great rationales. It was wonderful, but the correct answer is number 12 here. All right, good. Y'all working hard here. Great. All right, I forget who all I've called on today. Did I call? Kayla, did I talk to you yet?
No, I'm here.
Okay, thank you, Kayla. I don't know if I've called, I don't think I've called on you yet. What about dysrhythmias? Which one of these 14 actions would be best for the dysrhythmias?
One second.
Sure.
Like with dysrhythmia is the first one?
Yeah, for dysrhythmias, which one of these nursing actions would be most appropriate?
I would say 1.
Okay, what is a dysrhythmia?
When your heart is not like accurately firing, and it's not a
Okay.
consistent like heartbeat. So maybe like 14.
Okay.
52.
What can we look at?
Oh no, number 8.
All right.
Right? EKG monitoring.
Well, we're going to monitor, but can we really do something more about just looking at something, observing? Would you consider number 5?
Yeah, but that's definitely not the one I would have, like, that's not the one that jumped out at me at first.
Okay, let's talk about that. Did anybody pick number 5?
I did because like hyper and hypokalemia have a big effect on the heart.
But the
Perfect.
issue is number 5 is looking at acid base. Oh, I'm sorry. It does say electrolyte. Excuse me. Yeah. Okay. Sorry.
Yes. That's okay. Yes, great explanation. Number 5 is the correct answer. Yes, we're going to continue EKG monitoring, but we already know they have a dysrhythmia, and yes, we're going to monitor, but what can the nurse do to maybe help this patient besides just watching an EKG machine? Well, we can look at the electrolyte labs and see if there's something wrong with them, and maybe we can tell the doctor if there's something abnormal. So you always want to think about in depth what truly is going on with my patient and what can I do, not just monitor in this case. But that's a good idea, right? All right, how about activity intolerance? Let's see. Oh, I've done lost my train of thought. Oh, did I call you Tong? Have I mentioned to you, Tong? If I've already called you, just let me know. Tong, what do you think about activity intolerance?
Okay, you haven't called me.
Okay.
So I'll say provide a protein shake after each meal because activity intolerance could possibly come from low calorie intake, so the patient have low energy. So I do this by promoting proper nutrition.
Okay. All right. Does anybody else have a different answer?
I'd say number
11.
7, encourage paced self-care.
Right. That's the correct answer. Number 7 is the correct answer. So when we're looking at activity intolerance, we know that the patient is having difficulty doing things. So what we can help those patients, so they're going to do their self-care at a certain pace that fits for them, but they also want to rest. Giving them protein shakes obviously would be fine, but it's a long-term thing, a long-term goal. It could give them some more energy. But how can we fix the issue or the complication that is occurring now? Does everybody understand that rationale?
Why wouldn't it be number 3?
Because as what we want for our patients, we want them to be as independent as possible.
Okay.
And we can assist them, but even if we assist them, it doesn't say anything about rest and self-paced. But we also want our patients to be as independent as possible from nursing care. So for the specific complication that they have trouble doing things, we want them to be kind of slow at their own pace with periods of rest. Does that explain that?
Yes, it does.
Okay. All right, excellent. All right, Ashley, oral candidiasis. Are you there, Ashley? All right, I don't hear Ashley. Let me see. Taylor, did I call on you yet?
No, not yet.
All right, you get to have the oral candidiasis.
So for this one, I put it was in between 6 and 9. So for 9, that would definitely prevent it from getting worse. For 6, I'm thinking it might help it, it might treat it. So I'm kind of in between those two.
Okay. What do you say, class? Because she's decided between 6 and 9. Which one is really the most appropriate to help this patient who has this oral candidiasis problem?
I think I went with 9 because for 6 it didn't say what kind of mouthwash, but I don't know if that's right.
Okay.
I went with 9. I went with 9 because mouthwash won't necessarily help candidiasis. Candidiasis, you need an antifungal if you really want to
Well,
treat.
unless it's nystatin, yeah.
Well, if it's a nice statin mouthwash, yeah.
Right. Don't read into the question.
So it's not, yeah, I'm not reading this as nice statin mouthwash. I'm reading
Right.
this hospital mouth and alcohol. I don't know. Alcohol, I guess, is sort of effective. I mean, if they could rinse with what you call it, bleach, it would be great. But I guess that's not an option.
No. The correct answer is number 9. Absolutely. We want to make sure that it doesn't get worse, so we would just want to remind them to rinse their mouths. Remember, before, after using any type of inhalant steroid. Okay. Teaching them to swish and spit mouthwash 3 times a day is fine, but it's not really going to affect the corticosteroid and the potential for additional mouth problems. Okay. All right. Let's talk to, y'all doing good, Allison.
Hi.
Hi, Allison. You're going to get hypoxemia. What do you think you should do? Remember, this is a nursing action.
So this one is lack of oxygen in the blood. And for this one, I would do administer oxygen therapy.
You are correct. Definitely. Hypoxemia, obviously, we got to get some O2 in their bloodstream, so you're going to administer the oxygen therapy. Okay, good job. All right, we got 2 more here, and we'll move on. Andrew, can you do malnutrition?
Yeah, I got a quick question about the last one though. Like, should you try to get more effective breathing since they're exasperated COPD before the oxygen therapy? So the oxygen actually makes it into the lungs?
Okay, which one did you want to use? What did you say? What was the one?
I was for that last one, I was in between 1 and 2. I was thinking how good's oxygen therapy going to be if they're not breathing effectively, if the COPD was exasperated?
That's a good question. However, we've got to get the oxygen into the patient regardless of how they're breathing, and the only way to do that is to give oxygen therapy. We can later on teach him to do pursed lip breathing because that kind of concentrates the breathing. But right now the problem is that the patient has hypoxemia and doesn't have enough O2. We have to get it in there as quickly as possible. So we're going to give them oxygen. Mm-hmm. Did that help you? Okay.
Yeah, I was just not understanding how the oxygen was getting in.
Yeah. How about, did I say malnutrition for you? I can't remember.
I was going to say provide 5 small meals a day because of COPD.
You got it. That is absolutely correct. So malnutrition is number 4, yes, because they have trouble breathing and eating at the same time and it wears them out. And so definitely you want to do a little bit small meals. Even 6 small meals would work as well. Okay, the last one here is anxiety, which is a very common problem for COPDers. Oh, I need to call someone. Oops. Melissa.
I put number 14.
Okay, can you explain that one?
So I was in between 14 and which one? 10, but you don't know how the person deals with anxiety, so like you can't just tell them to deep breathe because maybe that's not how they deal with anxiety. So I picked 14.
I think you are absolutely correct. Absolutely. For anxiety, we want to help them develop some type of plan. What should they do when symptoms occur? One of the things they can do is turn the lights off and ask them to take slow, deep breaths. That's a possibility. But the best answer here is number 14. Great job. Yeah. All right. Everybody do good? Are you smiling? Any questions on this little scenario and developing your clinical judgment skills? Yeah, I see a couple smiles there. All right, I hope you did well. Again, those answers at the back of the PowerPoint for you. All right, so well done, class. All right, let's talk quickly about some lung cancer. It does increase when a patient gets 65 years and older. It's more prevalent in men. And of course, the mortality rate for the different ethnic groups, it varies. It's known that patients who smoke have a much more greater chance of developing lung cancer. And the common causes is pretty typical: chest pain, coughing, shortness of breath, wheezing, and lots of respiratory infections. But again, if a patient initially, sometimes a patient who goes to the hospital, to the healthcare provider, they may not suspect lung cancer, so they may not do any type of lung scan initially. So they might be treating them for what they see, like an infection or maybe some anorexia or some fatigue. They may treat them for that. But again, because lung cancer itself, cancer is painless, and until the lesion gets large enough to impede the tissues around it, then the patient's not going to be hurting. So unfortunately, by the time we see a patient diagnosed with lung cancer, it can be also a much more difficult thing to treat, right? But again, treatment, surgery, chemo, radiotherapy, which we don't need to talk about all of those things, but we do know lung cancer can be a problem for our older patients, and particularly those who smoke. Lung abscesses, again, are very similar to some of the others. A lot of the respiratory symptoms are very similar. It can be caused by all kinds of things. Basically all that's happening is that there's something inside the lung that's causing some pus to form, some bacteria to lodge in there. And then of course it has all those exotoxins, and it causes a lot of like mucus and pus. So we call that a lung abscess. And really the diagnosis is just treating the patient, getting chest x-rays, maybe doing some kind of CT scan. And the treatment, of course, high protein, high calorie diet for these patients. And we do some postural drainage because we have to drain that abscess out of the patient's lung. But not a whole lot we talk much about on lung abscesses. So what I want to do is we're going to review a few nursing diagnoses and interventions. All right. So this first one here, I just left the blank. The blanks mean time frame, and of course I don't have a time frame. So if you have a patient that needs this goal, you have to add the time frame. So let's look at impaired gas exchange. So here's the patient maintains a patent airway. The patient expectorates secretions from the lungs, and of course then you would add your time frame. That's our goal. So a couple things that we can do with impaired gas exchange. Remember, impaired gas exchange really relates to the fact that the oxygen and the CO2 is not exchanging very well in the small capillaries that surround the alveoli. That's what it means. So we can teach our patients some breathing exercises. We did these way back in fundamentals, and hopefully you have been using some of these activities with your patients if you need to. And I'm not going to read through these. I just want you to just review how to do teaching breathing exercises. There's another one that helps us to teach abdominal breathing, and I think this is kind of interesting. And we can all practice these to help with expiration. In a lying position, you can put a pillow or a book on the abdomen, push the abdomen during inspiration, and watch the book or pillow rise up and down. That really helps the patient to expire. And so then they would exhale slowly through those pursed lips while pulling in the abdomen. So they use their abdomen here for expiration when they have other things. So this impaired gas exchange is just a couple of actions. Okay. A couple of other things we can do for impaired, I just said that, okay. Impaired gas exchange, a couple of nursing actions. We can cough and deep breathe. Teach them to cough and deep breathe at least every 8 hours, all right? And also we can do some postural drainage exercises as ordered, allow rest periods, those types of things. Postural drainage exercises in the hospital are usually done by respiratory therapy, but nurses need to have some idea of in what positions to put patients when we are doing postural drainage exercises. The reason these are important for impaired gas exchange is because we're trying to get the oxygen and the CO2 to exchange, and this will help by getting rid of some of those excess fluids. Another one that we can do for nursing action, of course, is your antibiotics. All right. And of course, administer oxygen as prescribed, and be careful to watch for carbon dioxide narcosis. And let me explain what that truly means. It causes personality changes. If the patient has too much carbon dioxide, confusion, and coma, because of the increase in CO2 in the bloodstream, this is what happens. This can occur during patients who have COPD, and you're giving them oxygen. So we want to make sure that we are not giving them more than 3 liters of oxygen without a doctor's prescription for certainly. I have seen in my practice, I've seen COPDers in the hospital. One doctor one time allowed him to have 6 liters, but I tell you, I was 6 liters of O2 nasal cannula, and I was really watching that patient because knowing what could happen. And so, but we do know that we want to prevent CO2 narcosis. That's what that means, right? And of course, vaccines, if the patient has not been given these vaccines, we always like to do that. Also, if they're not contraindicated. So impaired gas exchange. Right. Now, the other one, nursing diagnosis, ineffective breathing pattern. This means the patient is having trouble breathing appropriately, okay? Right, and so the blank again here is for your time frame. So to help them with their breathing, we're going to teach them about some breathing exercises. We might, if they have pain or nausea or vomiting or any of those things, we have to control that before they will do their, until they breathe, because if they're really sick or nauseated, they're not going to breathe effectively, obviously. We want to make sure the patient's at 30 degrees, unless contraindicated, of course. We're going to do the turn coughing and deep breathing at least once every 2 hours. You can do more than that if you want to. And of course, you're going to, in this case, monitor their respiratory patterns, the color, whether they're coughing up, their ABGs, and their mental status. So ineffective breathing pattern. is also another one. We have impaired gas exchange and infective breathing pattern are two really good nursing diagnoses to use with patients who have COPD. Okay. Another one that we know is very good for these patients is called activity intolerance, obviously because they can't breathe very well. All right, so here's the goal that we might have. Well, let's look at some of the nursing actions that we can do. We have to, first of all, assess or determine how is their respiratory problem affecting their ability to care for themselves. We want to make sure we schedule rest periods. We want to find out anything that causes them or contributes to the problem that they can't have much activity, such as sleeping is not very good because they cough all night, or not understanding how to preserve their own energy. So these are things that we can do. And of course, we want to make sure we do some nutritional intake to support their activity. Some more nursing actions you can do for activity intolerance: monitor vital signs, obviously. And importantly is to discontinue any activity that causes any of this. If a patient has a change in their respiratory status, if it decreases or their pulse goes down, the systolic pressure becomes a problem, they become confused, any of these things, any type of respiratory distress, you're going to discontinue any activity. Now, obviously, we can use all of these for all patients, not just our geriatric patients. So which potential age-related change may result in a lung abscess from aspiration of foreign material?
C.
What I hear?
I said C.
C, absolutely. Decreased pharyngeal reflexes, yes. Right. If somebody is aspirated, could be anything, food or a child could do pennies, even though we're talking older adults, we're going to have some problems with getting rid of that, the secretions that come from that aspiration of that. So C is the answer. Some general nursing considerations, of course, medical attention, of course. Sometimes there is no chest pain. Remember, for the older adult and their body temperature is lower, and they could still be very, very sick. So we have to keep that in mind, because the presentation of a respiratory problem in an older patient is different from a patient who is younger. We also need to be looking at the sputum, the color of the sputum, how thick it is, all those things that we have spoken before about how to assess sputum. Remember, the green sputum could be infection. Sometimes yellow could be from allergies or even some infections as well. Okay, bloody sputum, it could be a lot of reasons. It could be cancer or some other thing. Okay. We always want to prevent complications, and that's what you just did in that exercise. You were able to try to, or at least potential complications, we wanted to protect the patient from that. So all of these things here is what you would assess your patient for when you're trying to prevent respiratory problems. Respiratory, you do your full assessment, your vital signs, you check the JVD, the neck veins. Do they have a patent airway? Are they coughing okay? Are they bringing up anything? If they are, what color it is? And of course, their mental status. Because with a decrease in oxygenation, as you know, hypoxemia can cause changes in the mental status. And also, if a patient is having an issue with too much oxygen and they're already a patient with CO2, with a COPD, we don't want them to get carbon dioxide narcosis. So we try to protect them as much as we can. So truly, class, when you're thinking about it, the purpose of an RN in some ways is really to try to be very observant and spot problems that could occur for your patient before they occur. And remember to remember that because your observation skills are important. Hold on, class. I need some water. I'm losing my voice today. I usually get this way when it gets close to leaving, huh? Okay. So far, so good. Oxygenation administration. Don't forget your carbon dioxide narcosis. Be careful with how much you give your patient. If you do have an order to give it more than the 3 liters that we usually kind of for our patients, just keep in mind that the patient can have respiratory depression from that. So keep in mind, just be watching them very diligently. Check those blood gases. This class is not going to go too much into blood gases. All right, but you know, you have to check that. Their oxygen equipment, make sure it's safe. If they're using oxygen at home, remind them that they need a no smoking sign and no cigarettes around it, no smoking, that kind of thing. All right. All right. I just wanted to remind you what hypercapnia is. Hypercapnia, C-A-P-N-I-A. It's a state of elevated serum carbon dioxide, and it's most severe when the patient gets that carbon dioxide narcosis. That's really what it is. One of the things that's really hypercapnia that really sets it aside from a basic hypercapnia problem is that with this carbon dioxide narcosis, there's going to be a depressed level of consciousness with carbon dioxide narcosis. Right. So if we don't recognize this patient is developing this problem, they can actually go into a state of coma or even death. So we need to be watching for that, okay? And it's most commonly seen in patients with COPD. All right. For postural drainage, and I know your ATI does test you, by the way, on postural drainage. So I just gave you a chapter here, chapter 53 in the ATI Fundamentals book on positioning patients with performing postural drainage. You might want to take a look at that, not only for this class, of course, but for your ATI and your NCLEX, but I just wanted to bring that to your attention. The whole purpose of the postural drainage, of course, is to get rid of the stuff that's in their lungs. Generally, what we'll do is that we'll give them a nebulizer or some other aerosol medication to kind of start breaking up and thinning out maybe some of the secretions. That way it's much easier when we're doing postural drainage. Think about when you have to do this, think about the positioning. It's got to be based on how the patient can be manipulated. And I have a picture here in just a moment to kind of show you. So you also have to know, can the patient tolerate the positionings that are, they're normally required? So you have to think about, can they do it or not? Can they tolerate that position? Even though there are certain positions, we got to make sure they can't handle it, right? But if the patient becomes short of breath, of course, any kind of heart problems, palpitations, or pain, gets too nervous, or other kinds of stress, you're going to have to stop the postural drainage. And of course, definitely have some hygiene, because that stuff is all coming up through that mouth, and let them rest a little bit after the procedure. So here is a picture of your basic drainages and what position you should put a patient in if you are taking out the fluid from certain areas. All right. So if you'll notice, let's look at this. If you're looking at fluid in the top of the lungs here, this is where the patient, this is where we're going to be trying to get the drainage out, and we'll do that right at the top, and we'll do our little cupping to get that out. All right, this is where, and that's what these are, little pictures are for. it makes sense, even if you don't memorize all of this, if you think about, and I don't think you have to memorize this, if you think about, okay, where is the abscess, where is the fluid or the stuff I need to get out, the secretions, where is it located in the lungs, and why would I put a patient on that particular side or laying on their back or laying or sitting up? Why would I do that based on where it's located? That will help you to be able to answer any questions that come up with postural drainage. And I think that will be useful for you. We do want to make sure that they cough productively, of course. Things to promote coughing, all right, would be hard candy, of course. That also helps increase those secretions. We talked about that a little bit already. Breathing exercises, humidified air is much better for patients. Generally, anything over 2 liters nasal canyon needs to be humidified because oxygen is very drying. Expectorants, there's lots of medications out there that we can get that also loosens the secretions and also liquefies secretions, and plenty of fluid intake will help promote that coughing and get that up. Not a lot on complementary therapies, really. I'm not going to ask you too many questions about these complementary therapies, but we just want to be watching for that. One thing to kind of remember is that if a patient has a lot of problems with mucus secretion, milk, if you ever drink milk, you notice it kind of makes your mouth be a little bit more mucusy. You might want to avoid milkish products or dairy products, particularly if we're worried about them having too much mucus. All right. So I'm not going to ask you a lot about complementary. That was in your textbook. And of course, yoga is a complementary treatment in respiratory conditions, and basically it increases deep breathing and tissue oxygenation. And that's something that we talked about. If a patient is interested in yoga, we know that it's all about deep breathing, and that deep breathing helps to oxygenate our lung fields. For self-care, make sure they know how to use their nebulizers. The MIDI nebulizer, making sure they know how to use the spacer, your basic, medication administration procedures. All right. Of course, I'm definitely not going to talk to you about ventilators. That's more of a med-surg discussion. However, your book brings it up, so I thought I'd just leave it on here for you. All right. We always want to encourage our patients because we know that with respiratory, patients get anxious very easily. They can't breathe very well. And so they need a lot of teaching and encouragement to get through. All right. So do you have any questions about respiratory? We just covered the, maybe 4 or 5 things that are the different conditions and some nursing diagnoses and what are some of the nursing actions that you can do. And importantly is how is aging affect the respiratory system? Here's the answers for your thing that we did today. So that's at the end. All right. Woo, all right, let's take about 5 minutes. It's 12:36. I'll take about 3 or 4 minutes or something just to kind of stretch a little bit so we can at least start on circulation and cardiology. All right. All right, any questions? No questions? Okay, it's 12:36. We're going to resume back here at 12:40. It'll give you about 4 minutes to stretch. All right. Okay, great. See you in about 4 minutes. And I'll get my slide up for circulation. There we go. Ooh, okay, class, I'm getting stiff here too. I'm sure you are. All right, so hope you all stood up and stretched a little bit. We only have about 20 minutes left, but I did want to get started on circulation. It is chapter 19. All right. Cardio, and I know you just had a bunch of EKG things recently. So hopefully this will be also nothing too new for you. Be sure you know the terms as always. What is an arrhythmia? All right. Atherosclerosis, very common for you. Hohmann sign. One of the things about Hohmann sign, we don't really test that anymore. I don't know if y'all realize that. But basically, if the patient does have a clot in the leg and it's dorsiflexed, the leg is dorsiflexed, it'll cause usually some pain. Of course, hypertension has a definition here as well. What happens with our older patients is that as a patient gets older and they don't do as much activity or exercise, that means their heart, which is a muscle, also becomes deconditioned. And so there is a decline in cardiovascular functioning in our older population. Postural hypotension, I've got a little extra stuff to talk to you about on this one. I think it's important. In your Canvas, I have attached or uploaded a handout assessing etiology of orthostatic hypotension. It's very good to read. It's important. It's for best practices for nursing of care of the older adult. It did come from the Hartford Institute of Geriatric Nursing. And so you actually have a copy of it, but I want to point out a few important pieces that I think you really should be familiar with on postural hypotension. According to the Hartford Geriatric, orthostatic hypotension is common in at least 30% of older adults. And we know because of that, it can lead to falls, it can lead to a diminished ability to function, and of course, their quality of life will be much, much less having this. The definition here is a decline in systolic blood pressure of 20 millimeters of mercury or more after rising and standing for 1 minute. Okay. So there's a slight variation in the definition on your Hartford Institute Geriatric information, but just a slight difference. They talk about within 3 minutes of standing, supine, and sitting. So that's a 3 minute for standing, sitting, and supine. However, at least a minute, class, just make sure it's at least a minute, and that will be sufficient. Okay. They do recommend that blood pressure and pulse should be recorded while they're doing the sitting, lying, and standing, not just the blood pressure. I think one thing that I thought was very good for students to know, and of course all of us as nurses, if the pulse rises over 20 beats per minute, while the blood pressure drops, it suggests hypovolemia, such as dehydration and acute blood loss. So if the blood pressure begins to drop during these exercises and the pulse goes over 20 beats per minute, hypovolemia is most likely the cause, whether from blood loss or something else, okay, dehydration. It could also be an adverse effect of medications, such as antihypertensives. All right, so I think that's important. The other piece is very interesting. If the pulse stays constant or rises less than 10 beats per minute and the blood pressure drops, it's probably an autonomic dysfunction. So let me repeat that. And you also have this in your Canvas, but I just wanted to tell you again, if the pulse stays constant when they're doing these 3 exercises or activities, and the pulse doesn't rise, or it rises less than 10 beats per minute, and your blood pressure drops, then it's probably something like caused by maybe diabetic neuropathies or Parkinson's disease, or even a vitamin B12 deficiency. So that's good to understand the differences for our older population, of the differences between what does dehydration look like when we're doing orthostatic examinations on our patients, and that's important. Okay. All right. If a patient does have orthostatic hypotension, it's important that the healthcare provider is aware of it, because there must be an underlying reason for it. It's just not that they just do it. So again, we just need to make sure that we're documenting it. And many times the healthcare provider will actually order orthostatic hypotensions in the lying, sitting, and standing positions, but it doesn't necessarily have to be. Keep in mind, though, if this patient has this problem and they stand up, we want to be real careful about having them stand up, because we don't want them to fall. You have to kind of remember that. They also recommend that the older population is screened on a yearly basis for this, because it's kind of common, and that the prevalence of orthostatic hypotension is more noticed in the hospital. And the reason for that is because the patients don't get up out of bed like as much as they should. And so they tend to be more immobile. Prolonged bed rest, remember, causes a lot of problems and deconditioning of the body and the muscles and all of that. And because doctors tend to order new medications in the hospital. So again, if you are working in a hospital, please be watching for any type of orthostatic hypotension problem, or also known as postural, but orthostatic hypotension, because it could be the patient has been in the hospital for a long time, or maybe some different meds. Excuse me. So that's important things to remember specifically about orthostatic hypotension. I will test you on this. I just want to make it clear, because I think it's so vitally important to understand when we are taking care of the older population. So be sure, if you didn't take notes or if you couldn't keep up or whatever, you have this in writing as well in your Canvas. I just want you to know that. All right, so let's talk about heart. All right, it's 12:47. I'm going to take roll in just a moment, okay? For cardiovascular, or actually circulatory system, things are getting better. There is a decline in heart disease, which is good. However, because there is a decline in mortality, unfortunately, it's still the leading cause of death, which kind of makes sense, because the heart, patient ages. And it is a major cause of disability in the United States, and particularly in our older patients. So what we do is nursing in circulatory system. We have to intervene for potential problems. Nurses, if you've been doing your, I know you do care plans and stuff. We're doing stuff for the patient, but we have to think that we want to prevent problems. Prevent those complications. So that's really a major piece of what we do as nurses. And your book actually mentions that as well. So we want to intervene to keep problems from happening, not just work on problems that the patient already has. All right, that's important. Okay. I'm going to stop here just as an introduction. We'll talk about the heart when we return. What is today? On Tuesday, we'll finish the heart in the endocrine system, because it will be on your exam next Thursday. And I'm going to take roll, all right, to make sure I have the attendance. So does anyone have any questions about all the many materials that you covered today? I really think you did a great job in participating in some of those activities. I hope it gave you a little feeling for how to be a critical thinker and a clinical judgment nurse. Okay, that's important. All right, so here we go. Just real quickly say here. All right. All right, Tommy.
I'm here.
All right, Samantha.
Here.
Ada.
Here.
Steve.
Hey.
Hey, Rebecca.
Here.
All righty. Mai.
Here.
Heather.
Here.
Leland. Are you there, Leland?
Yes.
Oh, okay, I barely heard you. Okay, I think I heard you. Alexis?
Here.
Okay, Kendrick? Okay. Uma?
Here.
All right. Anne Marie?
Here.
Emily?
Here.
Stacy Matthew?
Here.
Melissa?
Here.
All right, Andrew?
Here.
Yvonne? Yvonne, I know I talked to her earlier. Yvonne, are you there? Okay. Grace? Oh, I see you, Grace. Thank you for having your video on, Grace and Tong. I appreciate that. Allison?
Here.
Thank you. And Taylor?
Here.
All right. Vivian?
Here.
Oh, I did say that.
Here.
Oh, Taylor again. I'm sorry. I said, wait a minute. We have two Taylors. Second Taylor. Yes, you are there. Remember it. Okay. Amber. I see you, Amber. Thank you. Kayla.
Here.
All right. Mira.
Here.
Stacy. Sister.
Here.
Wonderful. And Logan.
Here.
Ashley.
Here.
Michael.
Here.
All right. And there's Maggie.
Here.
Kiyomi.
Here.
And Tong.
Here.
Okay. Awesome. Thank you very much. Yes.
This is Yvonne. I had some issues and Uma called me.
Okay, Yvonne. Thank you.
Thank you.
I wanted to make sure you were here today. And I think I talked to you earlier, actually.
Yes, I read the COPD case.
Yes, I remember I talked to you. Okay, thank you for responding. Class, it's been, actually, I've enjoyed this today, and I love your interaction and being able to answer those questions. You did really well with your thinking and all of that. So I hope you have a great weekend, and I'll be available if you need me for anything. And next week we will start on circulatory and the endocrine to make sure we cover that material for your exam on Thursday. All right, it's a 53 or what is it, 7 minutes till. I'm going to let you go, and I will definitely be around if you need anything. Okay.
Thank you.
Thank you.
Thank you so much. Have a good afternoon.
You too.
Okay.